Hello to everyone joining in and welcome. Thank you for tuning in for this important conversation on access to care, primary care, presented by Delta Sigma Theta Sorority Incorporated and Kappa Alpha Psi Fraternity Incorporated. I'm Sheila Williams, Vice President of Marketing of the Pulmonary Hypertension Division of Johnson & Johnson, the sponsor of this event. I also join you as a proud member of the Central Jersey Alumni Chapter of Delta Sigma Theta Sorority Incorporated. Tonight, I'm joined by an incredible panel of healthcare leaders ready to educate us on what primary care is, why it's important, how to access it, and useful resources we can use to drive health and wellness in our community. So let's meet our leaders. I'm going to ask each of our panelists to share your area of expertise and also your area of impact in the community, starting with Dr. Cassandra Scales.
Good afternoon or good evening. Thank you very much for having me today. My name is Dr. Cassandra Scales, and I am a board-certified OBGYN in the DC, Maryland, and Virginia area, also assistant chief of my department. Very excited to be here because primary care and women's health are my jam. I really love to engage and activate patients and communities in this space because we know that primary care is preventive care, particularly when it comes to women's health. I sit on the board of the American Medical Association as one of the House of Delegate members, so I do a lot of policy and advocacy work in this space as well. And I'm interested in disparities and reducing Black maternal mortality. So thank you so much for having me.
Thank you so much for being here, Dr. Scales. I'm going to pass it now to Ms. Sheila Williams.
Hello, my name is Sheila Williams, and I am a licensed speech language pathologist. And currently I am providing virtual services, but I also provide clinical services. My areas of expertise include pediatric care as well as geriatric care, specifically stroke patients, also school-age kids who are having problems in terms of communicating in the classroom settings and outside the classroom settings. I also have expertise in swallowing difficulties as well as strokes. Basically, I am a member of the Physical and Mental Health Committee of Delta Sigma Theta Sorority Incorporated. And one of my passions includes educating our communities, educating patients and their families, and being an advocate for them, which I think is very important in terms of today's healthcare world. So I am elated to be here tonight to share some of my experiences and background in the medical profession.
Thank you so much, Hilaria. So we have our Deltas on the line. I'm now going to pass it to Dr. Hernando Carter.
Hello, my name is Dr. Hernando Carter. I'm a board-certified internal medicine physician practicing in Birmingham, Alabama, doing primary care. I also serve as the National Health and Wellness Chairman for Kappa Alpha Psi Fraternity. So primary care is near and dear to my heart because that's what I chose to do for my career as my passion. I certainly am all about access to primary care, definitely increasing access in our community as a way to help improve health equity and reduce healthcare disparities. I am also very organized in organized medicine, very involved in organized medicine. I sit on the state medical board, serve as the vice chairman, currently sit on the state public health subcommittee and on the board for our state medical association. So very involved in trying to tackle issues surrounding access to care, whether it be the lack of primary care physicians, the lack of insurance coverage and the like, and also have a nonprofit organization that my wife and I founded, whose mission is to reduce healthcare disparities by increasing access specifically to culturally competent African-American healthcare providers. So happy to be here.
Fantastic. Thank you, Dr. Carter. And last but certainly not least, I'll pass it to Mr. Ken Johnson.
Good evening. I'm Ken Johnson. I'm a licensed psychotherapist, social worker, wellness consultant, and I serve as the EAP Clinical Director for the United States Postal Service, providing EAP services for over 140 postal facilities. I also run a private practice in Philadelphia, providing counseling, coaching, and consultation for individuals, groups, and organizations covering a variety of wellness topics. I'm a fall 2023 initiate of the Philadelphia alumni chapter of Kappa Alpha Psi Fraternity Incorporated. And I come to this work as someone who believes that given all that Black people have been through, we should be able to live as healthy as possible for as long as possible. And I'm grateful to be in conversation with this distinguished panel to discuss our topic for this evening, primary care.
Thank you so much, Ken. So as you can see, we have, as Ken said, a very distinguished panel, and we're going to attack this from the physical health standpoint, from the mental health standpoint. So I'm going to dive into some questions, but at the end, we're going to come back for your questions. So for those watching, anything that we don't cover or anything that this sparks for you, please put it in the chat, and we're going to come back at the end and try to answer as many questions as we can. So Ken, I'm going to start with you just to ground us in the language. What is primary care and what role does it play in our overall healthcare?
In a rather succinct explanation, primary care is the first point of contact for individuals seeking healthcare services. In many ways, it serves as the foundation of the healthcare system, and it encompasses a wide range of essential medical services provided by healthcare professionals, typically comprising physicians such as Dr. Carter, nurse practitioners, physician assistants, and in some cases, social workers. And we know that primary care providers are trained to address a broad spectrum of healthcare needs. They're able to coordinate care across various specialties. So if you need a referral or a consultation for a specialist, they can facilitate that process. Primary care physicians promote preventive care. In addition to health maintenance, they manage chronic conditions. They diagnose and treat a wide range of acute health problems, injuries, illnesses. They could prescribe medications and offer guidance on self-care, as well as offer suggestions for symptom management. One of the central aspects of primary care physicians in primary care is that they're able to develop a long-term relationship with their patients. So in many ways, primary care plays a very vital and important role, not only in preventive care, but also improving health outcomes for individuals and communities. And certainly we have some distinguished physicians on our panel who may add to my overview if I left anything out.
Thank you so much, Ken. Anything to add from the other panelists?
Perfect definition.
Perfect. Well, the title of this session is not just primary care, it's access to care. So Dr. Scales, I'll come to you. Why is access to primary care so important, or such a topic that Delta Sigma Theta and Kappa would bring this topic forward for Black and Brown communities tonight in particular?
So thank you for that question. I think the biggest thing is that access to care is a way for us to prevent people from getting sicker, but also to keep them out of the hospital. So we're talking about prevention. Those things that were mentioned previously about reducing chronic conditions such as hypertension, diabetes, high cholesterol, heart disease, all of those things over time, if they are not being managed properly, or if they're not being paid attention to, can get worse. And one organ system relies on the other. So if we're not paying attention to ourselves and we don't have access to the caregivers that can notify us if something is wrong, then we're more likely to have poor outcomes. And the data shows that. It shows that we are more likely to have complications from hypertension, diabetes, heart disease, lung disease, cancer, maternal outcomes, all of those things. Because if we do not have the proper support systems around us with the knowledge base to understand what are some of those signs that we need to be looking out for, then that puts us as a people and as a community behind the 8 ball when it comes to our health, but also with our life expectancy. The data has shown also that having physicians and healthcare providers of color actually helps to improve your life expectancy. And all-cause mortality is reduced just because you have somebody of color on your team. So having people that look like you does help to save your life.
Dr. Scales, when you think about all of the conditions that you mentioned and how important primary care is, it makes you wonder why we're not all taking advantage of it, why the access is held back. And I wonder if part of it is understanding what that experience is like. So I want to, again, stick just with the basics to start and ask Dr. Carter, can you bring the experience to life? What typically happens in a primary care visit so we can understand that aspect?
Yeah, sure. So I think that, the anatomy of the primary care visit has several components. First, I think everyone should realize that really the primary care visit begins before you even get to the doctor's office or before you show up for the visit. You typically, this day and age, will be asked to participate in some sort of pre-registration process where you will provide some basic information such as insurance information, demographic information like your age, your address, your sex, your race, etc. And then once you show up to the visit, I think the next component is that check-in process. So you walk up to a greeter or you walk up to someone who's working the front desk, a receptionist, and you will let them know you're there. You may be again asked to confirm your insurance information and some of the information that you submitted online, just because they want to make sure that everything is still the same, nothing has changed, nothing was entered incorrectly. So you got some paperwork to do. But then once you get called back, that is really when the visit begins in earnest. So again, even before the provider walks into the room to see you, you will typically have either a nurse or a medical assistant who will greet you, bring you back. They'll sit you down, and then at first just try to get to know you a little better. What brings you in today? What were your reasons for coming in? They'll want to get some, history and background about you, your family history, which is important for us to know our family history, any personal medical history that we may have. They will also, check your vital signs, your height, your weight, your blood pressure. All those things kind of happen during what we call the intake process, and then the actual visit with the provider. So what a lot of people should understand is that the clock really starts ticking once you hit that waiting room. And, our goal is, believe it or not, to get you back to that exam room as quickly as possible and for your provider to be face to face with you as quickly as possible. Typically, a lot of providers will review information about you before they come into the exam room. Sometimes if you have provided records, sometimes we can do record requests or searches before we go into the room to kind of get a feel for, some of that medical history background so that we can really spend time talking to you about your individual reason, your very personal reason for being there today before we kind of just launch into a litany of questions. And then, so a good doctor will sit down and talk to you, ask you questions, answer your questions. There'll be a conversation. There should be a physical exam that takes place where, the doctor examines you to make sure that they don't detect anything wrong, they don't detect any abnormalities, and then discuss findings with you, review things with you. And then after you leave, it's still not over because there'll be follow-up, particularly if your doctor did any tests. They'll need to follow back up with you to let you know the results of those tests or any other recommendations that they have. But in a nutshell, that is the kind of what I would call the anatomy of the doctor's visit. And there's a lot packed into a very small amount of time, right? I talked about a lot of stuff, and typically all of these components take place in about an hour or so, give or take, just depending on the situation. But that's what you can expect.
Thank you, Dr. Carter. I think one of the things you said is the preparation. And I know that at the end of our session, there are some resources that are going to be shared on questions you can think about asking, information you can prepare. So just to let people know, there will be some resources to help know what to take in so that as much time as possible can be spent talking to your doctor. I want to bring it home to the Black community and specifically. So what are to Celeria, I'll start with you. What are the primary barriers faced by Black Americans in assessing primary care services? It's often said that to get to the right solutions, you have to understand the problem. So what are some of the primary barriers that you see for our community in particular? Celeria, you're on mute.
But it was off.
Perfect.
Yes, thank you. I'm sorry. Current data continues to support and indicate that there is a large disparity of healthcare outcomes, especially in our Black and Brown communities, specifically in the areas of heart disease, strokes, infant mortality, diabetes. You name the conditions. However, in terms of what are some of the factors include perhaps maybe inadequate or maybe zero healthcare coverage. There's also considered to be, just in reading, there also seems to be declines in the healthcare workforce initiatives, not enough doctors, not enough providers, healthcare providers to address some of the concerns that affect our Black and Brown communities. Also, social economic factors such as education. Some of our communities and those who are in our communities requiring medical attention may not have the education that's needed to ask the correct questions, to seek the kinds of assistance and medical help that they need. Also, we look at residential segregation. Basically, you look at communities. There are communities where little to no assistance or help is provided for them. However, in other communities, they have what we consider a plethora of activities and events to help them, especially when we look at what is called the Silver Sneakers program. Some of our residents and some of our Black and Brown communities don't have access to those kinds of programs. We also have some other environmental kinds of things that prevents them from getting the kind of help and the kind of assistance that they need. One in particular includes perhaps maybe the physician's behavior or maybe the physician's attitude toward providing care to our underserved communities and underserved patients. So there are quite a few that we tend to see in terms of not being able to get access to the quality and the kind of healthcare services that are needed within those communities.
Celeria, that list is a robust list in itself. I'm going to ask Ken, because I know, Ken, you're active in the mental health space. Do you see additional barriers to those that were mentioned?
Absolutely. And thank you for the question. And Celeria, thank you so much for providing several barriers to primary care treatment. And if I may, I'll just add a couple, but just for the interest of time, I'll just outline maybe a few, because there are so many barriers that get in the way of many in the Black community from seeking the necessary care. And Celeria, you may have touched on this, but limited access to healthcare facilities. Some Black people are living in medically underserved areas with limited healthcare facilities and limited transportation, i.e. hospitals are too far. Residents may say, well, who can take me? I don't drive, it's too far to walk. So how can I even access the healthcare facilities when they're not in close proximity to where I live? We also know that there is cultural mistrust of the healthcare system in the Black community. Historical injustices, including unethical medical experimentations, discrimination, disparities in healthcare delivery, have contributed to a legacy of mistrust in the healthcare system among Black people, i.e., Tuskegee, Henrietta Lacks. This mistrust can lead to reluctance to seek medical care or follow recommended treatments, which can exacerbate some of the health disparities that we have in our communities. The next two barriers that I like to cite are really important to consider, one being fear and anxiety. For some Black people, there's fear, anxiety, and apprehension about having contact with the healthcare system. Some men that I know say, I don't like hospitals. They're afraid that they don't know what news a provider may give them if they do go. So the fear and anxiety about even having contact with the healthcare system can impede individuals from getting the necessary screenings, the diagnostic tests that could be helpful. We know that negative past experiences, fear of pain or discomfort, some may have fear of needles, and mistrust of medical interventions may lead to avoidance or reluctance to seek necessary healthcare services. The next barrier that I would like to offer is stress and maladaptive coping. Many Black and brown people live with chronic stress, adversity, and trauma related to systemic racism, socioeconomic disparities, and environmental injustices. So when Black people have high levels of stress and coping strategies turn to avoidance, denial, or self-reliance, those strategies may interfere with healthcare seeking behaviors and make it difficult to follow through with primary care recommendations. And lastly, and this points back to what Celeria had indicated, that simply there's a lack of primary care providers. Simply there aren't enough Black primary care practitioners given the population and the demand. So this is not an exhaustive list, but it is a snapshot of several barriers that confront Black people as it pertains to accessing primary care.
Ken and Celeria, you have to pause over those types of questions, because when you start to stack up the barriers, it can almost become overwhelming, the things that you mentioned. But one thing's for sure, that if each of us on the line could just go back and say to a family member, when's the last time you've been to your primary care doctor? I'll go with you. Email the resources that are going to be shared. We know that we can drop down those barriers one by one, but thank you for giving us the reality of what we're up against as we support our communities. One of the reasons why primary care is so important is because a lot of times, as was said at the beginning, primary care can be a gateway to seeing the different specialists that we need for the conditions that are rampant in our community. So I'd like to start with Dr. Scales to ask, how can people navigate when they need to see their primary care physician versus a specialist, and how do they make that happen for themselves?
Thank you so much for that question. So I think kind of taking a step back in terms of understanding how insurances work is going to give us some clarity on this question. So most insurances, you'll either have what's called an HMO or a PPO. And what does that mean? HMO stands for Health Maintenance Organization, and PPO stands for Preferred Provider Organizations. This type of insurance, depending on which one you have, will give you access or choice based off of what your insurance plan will provide. Most people will have an HMO insurance because it is lower in cost. And typically, what happens is that your primary care doctor is, as Soror Williams said, a gatekeeper towards access to other services. And that's not necessarily a bad thing. So, a lot of times people want to come in and they want to have the super high specialist care right from the beginning when you may not necessarily need that. Um, it's a lot of times people will say, well, I'm high risk, I have these issues. And there's some things that your primary care provider can actually handle. And then if they need some additional assistance with subspecialist care, then they can get that for you. And that helps you because that helps to decrease your cost in terms of your copays, but then also making sure that you have somebody that has a touch point on you throughout your entire journey. If you've ever been in a situation where you go into a hospital, for example, and you get a lot of people coming in, you got the pulmonary person, you got the cardiology person, you got all of these people that are doing their thing. They're focused on their thing. The benefit of having a primary care doctor is that they can help to bring all of that stuff together. So they can take every little piece of what those specialists are doing, and they can bring that into what you as a whole person needs to be able to be well overall. With PPO insurance, you have a little bit more flexibility in terms of choosing when you want to go out of network, when you want to see a specialist, but that comes at a cost. So there's pluses and minuses to both aspects of it. As an OBGYN, I sit in the middle. So I am a primary care provider. So I see patients from youth all the way until the end. I also am a specialist because I do surgeries. I provide specialist care, but there's differences in how I wear my hats depending on what the need of that patient is at that time.
Thank you, Dr. Scales. Dr. Carter, anything to add from your perspective?
Yeah, I would say that to answer the question, in my opinion, the first stop should always be to your primary care provider. That's the purpose of that relationship. Whenever you have something that's going on with you, you don't know, for example, it could be chest pain. Human nature says that if my chest is hurting and I care about my life, then I'm probably going to have some anxiety and I'm going to think worst case scenario, what's going on, right? And particularly if you go to Dr. Google and you put in chest pain, then probably the top things that are going to result from that Google search will be the things that, are catastrophic, whether it be a heart attack or a ruptured aneurysm or just something really horrible, when in actuality, it could be those things, but more than likely it could be heartburn or acid reflux or musculoskeletal pain or a pulled muscle. And so, in order to make sure that you are receiving the correct level of care and actually the correct kind of care, going to your primary care provider first is always the right thing to do when you're considering, should I go to this specialist? Should I go to that specialist? Because your primary care provider, particularly if you have a relationship in which you trust him or her, they're going to listen to you. They understand your history, and they're going to be able to advise you, hey, this is the course of action that I recommend that we take. Here's what I think is going on based off of, your history and what I know about you in your exam. So and sometimes I've seen even patients that come to see me, maybe for a new patient visit, they've seen several different specialists for the same problem. They may have seen a cardiologist, they may have seen a pulmonologist, and then they've seen, an orthopedic specialist. And the thing is that, to a hammer, everything looks like a nail, right? And so when you go to that kind of specialized care right off the top at first, you're going to get what they're able to provide, what they have that access in. What they have that training in, what they have that expertise in. And, they may not take a kind of broad approach to begin with. So, I certainly think that the right thing to do is to go to your primary care provider first, which really leads into a good point that we shouldn't really wait until we have an issue or until we have a crisis, to find a primary care doctor, to try to establish care with a primary care provider. Because we've, said since this whole conversation began that there is an issue with access to primary care. There aren't enough primary care providers to take care of people who need a primary care provider. That means that for a new patient appointment, there could potentially be a very long wait, especially if that primary care provider in your area has a really good reputation. A lot of people respect and trust them. Their patients like them. They're going to have a long waiting list. There could be a 6-month or more wait for a new patient appointment in order to establish with the primary care doctor. And a lot of people, once they get to the moment of crisis or they have something going on in their bodies and they don't have a primary care doctor, they have to wait 6 months. That's too late, right? So they go to the emergency department and get primary care there. So I would encourage people, don't wait. Don't be intimidated by, the thought of trying to find a primary care doctor. You're feeling okay now. Now is the time. Go ahead, do your research, find a primary care provider, make the appointment because there's probably going to be a wait, and, keep that appointment. Once you have established with the primary care provider, access to that primary care provider becomes so much easier, just because there's only so much time in the day. They're only going to have so many slots on the schedule for appointments for patients. And so there will be more available appointment slots for patients who are already established with that primary care doctor, because we've already committed to taking care of your health care, to seeing after you, as opposed to someone who's trying to establish, who's trying to get into the door. So don't wait. Go ahead and establish. And then once issues or concerns arise, see your primary care doctor first, or your primary care provider first, and then they can guide you to what's the next step, the next level of care.
Dr. Carter, as I listen to you and Dr. Scales, one theme is that there's a relationship with the primary care doctor. Ken said earlier that there could be stress if you've had a bad experience with another primary care doctor, or you could be afraid that as a Black man going in, who you see may not understand you, may not get you. So for those who prefer to see a Black doctor, to make that step, to make that proactive appointment, are there resources available for Black patients to find Black doctors in their area to at least help bridge that cultural gap for some? And that's to Dr. Carter.
Oh, yes, absolutely. So I'm going to say that probably the most important resource is going to be your network. Personal referrals always trump everything else, right? And I see it a lot. I mean, people even now utilize social media. They get on Facebook, in search of a Black male, Black female, a Black primary care provider. And then a lot of times the comments just light up. Sometimes, you can be on the wrong end of those of those comments if you have not had a good experience with some people. But, so personal referrals, who do your family members see? Who do your church members see? Who do your sorority sisters or fraternity brothers see? Someone in your golf group, whoever that network is that you trust. That's the first. So, personal referrals always trump everything else. But then you should know that, there are organizations out there like the National Medical Association, or NMA, which is a organization of Black physicians of all specialties, right? And then NMA have chapters in every state. In a lot of the major cities, they'll have chapters there that can direct and guide you to Black providers in that area. Also, all states have a state medical association. And then under the state medical association, there are other local, whether it be your city or county medical societies, and they're easy to Google. Like if you live in, for example, Jefferson County, which is where I am, you can Google, medical societies in Jefferson County, and it'll pull up Jefferson County Medical Society. And you can call there and say, hey, I'm looking for a doctor. I'm looking for this type of doctor. And more than likely, they will have, a member of that medical society who fits the criteria that you are looking for. You can also use other internet sites. There's an internet site called findablackdoctor.com. There is another one called blackdoctors.org that you can, locate in most states. There are some states that, they haven't built out the directory, but you can, at least have a starting point there and try to locate Black providers. But again, to recap, just your circle, just like if you would, hey, who do you go to for a barber? Who's your tax person? Who does this kind of work for you? Who's your primary care doctor is the way to go. And then, from there, the NMA, state and local county medical societies, and then doing web searches. Also, your insurance, a lot of times, depending on who your insurance carrier is, they will have a directory of physicians in that area, and it probably won't list out race, right? But sometimes they'll have as a part of that directory, they may have pictures of the providers, or, a lot of times just using that directory as a starting point and Googling names, you can find their website, you can find a picture of them, you can read their reviews. Health Grades is another site that you can go to. So, there are a lot of resources, but I always like to start with relationships and start with the personal touch first.
Outstanding resources, Dr. Carter. Thank you. Thank you for those. When you find yourself in a space where it's hard to get to a doctor, I'm struck by how common telehealth has become, especially over the past few years with COVID. COVID was a lot, but one of the things it seemed to do was to make telehealth more common, more popular. So Dr. Scales, I'd like to ask you, what is the role and the benefits of telehealth as it relates to primary care?
Yes, so COVID changed a lot in terms of how we think about care should be given. It used to be a time where you thought that you needed to go into the office for everything. It didn't matter what the complaint was, you just had to go and physically see the doctor. But COVID turned that upside down. The data has shown that about 5% of primary care doctors were using telehealth prior to COVID. That jumped up to 46% during the pandemic, and it's trending towards up to 70% of all primary care providers putting some form of telehealth into their practice. It's actually not a bad thing because it allows us to be able to have more reach beyond our doors. Just like Dr. Carter mentioned, there's a lot of times where our appointments are far and few between, but there's options for us to get creative about how we can be able to answer questions. Because a lot of times patients will come in and they just want their questions answered, or they get some results and they just need somebody to tell them it's okay, or you need to follow up. These are things that are easily managed with a phone call or even with a video visit. A lot of practices are now starting to outfit themselves in that space, so it makes it a lot easier for people to have access to that and for patients to be able to utilize it in a very streamlined way, including managing chronic conditions like hypertension and diabetes in terms of follow-up and checkups, to doing things like acute triage for, I've got this cold, what do I need to take? Or, I did something to this part of my body. Do I need to go to the emergency room? A lot of that has allowed us to be able to filter through what do people need to get care for now versus what can they do at home with some guidance. Mental health, my gosh, it has opened up the doors for people to have access to mental health providers. My husband is actually a mental health therapist, and his practice got started in the middle of COVID, and he didn't know what to do. He had a whole office planned out for him, and then boom, COVID hit. What he was able to find out was that he was able to reach people in other parts of the state that he didn't realize that he could have access to just because they didn't have to come into the office. So there's so many things that telehealth has done to really expand how people access care, and you'd be surprised who's accessing the care. Now, you would think that it would be the younger folks that are accessing the care. But what the data has shown is that people over 45 and above, and actually people over 65, are the highest utilization users of telehealth. The younger folks don't do that. They go, they want to come into the office and be seen. So it's very interesting that's what the data shows. Now, in terms of some of the barriers, regulatory guidance has changed a bit. They had to do a lot of emergency things related to COVID access to emergency care services because people physically couldn't come in because it wasn't safe. So now we're dealing with how do you regulate that care across state lines? What does that look like? How do you get coverage for some of that, what we call asynchronous care, via emails and things like that? So I think that those are some of the things that are conversations for the future. But telehealth has definitely, I think, improved our access to our patients in a much more unique way.
Thank you, Dr. Scales. I've used telehealth myself. It was convenient, it was fast, and it was right in my house. So definitely endorse that as one of the options. We have just a few more questions, but I just want to encourage those watching to please submit your questions. We're going to switch now into what we can do about all of this. As those watching, as the organizations that we serve in, what can we do and what resources we can share with all of you to help you do that work? But we certainly encourage you to put in any question you have because we want to transition to those soon. So Ken, I'm going to pass it to you and ask, what can we do? So how can healthcare providers, how can organizations address cultural barriers that may prevent Black Americans specifically from seeking primary care? How can we make this care more relevant?
Thanks, Isha. In my estimation, more healthcare providers as well as organizations must be willing to affirm the humanity of Black people. And what I mean by that is W.E.B. Du Bois tells a story in Souls of Black Folk where he asked, where he was asked, what does it mean to be a problem? And we know historically, Black people have been viewed as problems rather than people with problems, just like any other people. And it's my view that healthcare providers and organizations should receive ongoing training and cultural competency to better understand and respect the humanity, the cultural sensibilities, the values, and the practices of Black people. Secondly, healthcare organizations should also work to reflect the diversity of the communities that they serve, which includes being intentional about hiring Black healthcare professionals. We know that Black patients are more likely to feel comfortable, more likely to feel seen, and more likely to feel validated when there is a shared cultural identity and or experience with their provider. The last point that I would like to share is that healthcare providers and organizations must tailor their treatment and care to the specific needs of Black patients. And what I mean by that is, given the realities of historical trauma, racism, discrimination, and a host of other realities, healthcare providers have to create safe and supportive environments that validate the experiences of Black patients. That when a Black woman says that she's hurting, that her pain is intense, we hope and trust that her concerns will be validated and she's not dismissed and told that she will be okay because her provider somehow assumed that she has a higher pain threshold because she happens to be Black. So ultimately, Black people have specific needs, that require specific kinds of care. And certainly this is more than reasonable for us to ask.
Very powerful, Ken. Solaria, anything to add to that from your perspective?
Well, I can certainly say this is one of my favorite questions. And in my experience, I always say education, provisions in terms of providing those resources to our underserved communities, and also accessibility, making it accessible to them, bringing it to them, but also to, the old saying and the old adage is, if you build it, they will come. So I look at that in terms of saying that if we make it available to those communities who do lack the opportunity to travel or to be transported to these community, or maybe even to their hospitals or maybe clinics to get the services, is to try to make it available for us to be a voice for them, to advocate for them as well. One of the things that the National Council of Negro Women has done, especially during the onset of COVID, they initiated and launched an initiative through Good Health Wins to be able to provide COVID vaccinations to those underserved communities. And that initiative continues to grow because now they are providing not only COVID vaccinations, but they're also providing flu vax. They're also providing pneumococcal vaccinations as well as RSV. So from that, they're reaching the community. We're providing education. There are also mobile health units, clinics that are being provided to address some of the specific diseases and other concerns that we have in the community. There are health fairs. We also have our Divine Nine organizations who are providing even town hall community meetings to have local community, even healthcare providers or others who are associated in the healthcare industry to come in and provide information to the communities regarding what's available to them. So I think there's a lot of avenues and resources. And even tonight on this webinar, it is a very active way of providing information to our communities as well as to others in terms of how we can get started in supporting healthcare coverage and also accessibility for those who are living in those underserved populations and areas.
Solaria, can you please repeat the name of the first program you mentioned that's providing care, flu care? I want to make sure people can take that down. What was that organization?
Yes, it is the National Council of Negro Women, and they have launched what is called Good Health Wins. And basically, it helps to support the availability of free and maybe low cost COVID vaccinations, and also provides literature to the underserved communities. But not only does it now cover the cost and accessibility to COVID vaccinations, but it also provides availability and access to flu vax, RSV, as well as pneumonia. So these are some of the things that are happening. And I know that a lot of the Divine Nine organizations are supporting this in their communities and providing information, health fairs, screenings, also mobile clinics and mobile units, talk and go kinds of lunches to get the community involved. So there's a lot more in terms of education and information that is being factored into our underserved communities.
Thank you so much, Solaria. I see questions coming in. So as we transition to that, I just want to ask our panelists one question before we get to those other questions, which is guide us, challenge us, help us. For those of us on the line who are listening, as individuals representing organizations, what would be your parting thought on what more we can do personally to increase awareness and utilization of primary care? And then we'll get into the audience questions. I'll start with Dr. Scales.
So I think one of the overarching things here is building trust in the community. So there's a lot of things historically that have happened to our people that have validated their fears. And the problem that we have right now is helping our community to know that they still should get access to care if they have it available to them, and trying to build up that trust. And one of the things that I love that we're doing as a community is utilizing our infrastructure and our historical organizations to be able to have those conversations. Because just as Dr. Carter said, talking to a family member, talking to a church member, talking to somebody that you know will more likely than not get you into the office. We do know that at least 12% of people that are of color do not have health insurance. So being able to make sure that they're able to sign up during the times when open enrollment happens so that they can have some access to care is important. But then also, if you are a part of an organization that does want to outreach our communities, utilize our organizations to be able to do that, because we are here and we already have the infrastructure in place. So it seems like that would be the natural fit.
Thank you, Dr. Scales. Use the resources around us. Ken, what would be your call to action for us?
My call to action is for us to realize that we're in a deep health crisis in the Black community. We're disproportionately affected by cancer, obesity, hypertension, mental illness, chronic stress, diabetes, heart disease, and many other illnesses that can be prevented with appropriate education, timely screenings, and humane, culturally competent interventions. You know, for Black people, we're usually the last to ask or receive help and the first to die in terms of life expectancy. And getting more people into primary care appointments or educated about their wellness and their relationship to primary care can help. We have to continue to be intentional to fight to reduce the many barriers to primary care services. Additionally, we have to encourage more of our young people to pursue careers in medicine, the health sciences, and healthcare policy to advocate for the needs of Black people. We simply don't have enough Black providers, as we've stated multiple times during this webinar. Thus, it's incumbent upon all of us to prioritize our health and wellness, to advocate for one another, share information, lobby our politicians, create, cultivate, and collaborate with organizations who are willing to share their resources and partner with members of the community to create change, such as our partnership with Johnson & Johnson. In order for things to be different, we have to be willing to become different and do things differently. So having regular conversations to reduce stigma and encourage follow through is important. And ultimately, my call to action is community care is primary care. And primary care is paramount for the overall well-being and survival of many of us in the Black community.
Thank you so much for that, Ken. I'm going to shift to a question. And so, Larry, I'm going to give this question to you, but any of our panelists, please fill in. A question has come in from Stephanie English. And the question is, how can we better advocate for the care of our beloved ones who are seniors and to get them access to primary care?
In my experience, especially working with the the elderly population, geriatrics, I have found just being that voice for them, also advocating for them, also seeking their family members and pulling them along as well to educate them on the needs of their loved ones and making sure that they are available to be there for them, either to accompany them to a doctor's visit, to help them to make some very hard decisions regarding their life, their lifestyle, and the changes that are happening to them. So my approach and my passion for the geriatric population is to be that voice for them, to be there for them, to provide them with the necessary resources, but also even going the next mile, and that is doing it for them sometimes. Sometimes they just need someone who they feel really cares enough to get the ball rolling.
Thank you. Any bills on that from the panel?
I'll take another point to this. So as we get older, our care gets more complex. There's a lot of things that happen to our bodies over time where there's a lot of things that need coordination of care, but also of medications, how you manage it, and things like that. And I think that is very overwhelming for seniors to be able to do that alone. So, just as Solaria said, having someone who is there to help them to keep track of those things is going to be very important, because there's a thing called polypharmacy, for example, where you can have a bunch of different medications that are combinations together. But if you have something switched, it's just a lot of confusion. We talked about telehealth. And yes, there are seniors that are above 65 that are using it, but sometimes accessing some of the things that they need in terms of using their appointments can also be a challenge for some of our seniors. So being able to help them to navigate that is also important. And it's a generational shift now. So there's things in the past where someone that's above a certain age may not have asked the question because they didn't want to bother the doctor, versus someone else who is younger who is more likely to ask additional questions when they're at those visits. So having somebody there that's able to write down the questions that that person has, addressing their fears to the doctor where they may not feel comfortable doing because that wasn't the way that they were grown how they were taught earlier on in life, to be able to have that doctor-patient relationship.
Thank you, Dr. Scales. I'm going to pass a question to Dr. Carter just to get in as many as we can. This is a Facebook question. It says, why are Black men afraid of getting their PSA test and a colonoscopy to check for colon cancer?
Sure. So there's fear, I guess, embedded in the question, right? Why are they afraid? But it's the fear of the unknown. There's also a stigma, right, of having to undergo that kind of examination. For example, colon cancer screening, we think about the colonoscopy. And so a lot of men are apprehensive about somebody, playing around down there, which is the same reason why they're apprehensive about prostate cancer screening. So, but a lot of that we can overcome that with information and education. For example, prostate cancer screening now, what most men are afraid of is what's called the DRE, or the digital rectal exam, the actual exam where you feel the prostate. But now we know that a blood test, the PSA, which is a simple blood draw, is actually more sensitive and more specific for prostate cancer screening. So I can see in my own male patients, when they come in and we start talking about what kind of screening tests we're going to do, and we get into talking about prostate cancer screening, and I say, here's what we're going to do. We're going to do this blood test. And they say, okay, doc, so are you going to have to check it? And I say, no. For screening, we just do the blood test. And then there's just relief that comes over. I do kind of couch that and say, hey, if you are having symptoms, then we should still check. So if you're having problems urinating, if you're waking up at night urinating, if you're seeing blood in your urine or in your semen, we should still do the actual exam. But if we're talking about just coming in for my physical, I'm going to get my prostate cancer screening, PSA blood test. Same thing with colonoscopy. It's invasive. What guys say is, hey, doc, down there is out and not in, right? But when you, again, explain the screening options to them, that, hey, we do have options to do a stool test. Well, we can mail a kit to your home. You go to the bathroom, which is what you're normally going to do, catch a little sample, mail it in. And if it's normal, then you're to the good and your screening is done. If it's abnormal, then we know we have a sense of urgency to go ahead and get that full colonoscopy done. When I explain the full colonoscopy to my patients, I tell them, look, you're not going to remember the colonoscopy because they're going to give you medication to relax you and put you to sleep. And then they're apprehensive about that. And we have to kind of discuss that, how it's a simple process, it's easy, and we just kind of walk them through it. But a lot of times it's just kind of answering questions. They've heard, sometimes incorrect or inaccurate stories about what happened to other people. It's just kind of, smoothing over and assuaging those concerns. Again, I think that with a lot of Black men, it's about having to be able to be vulnerable, and we're not traditionally raised that way, to be vulnerable, to have ourselves in a position where we're not in control, to have ourselves in a position where we have to yield control to someone else. And so in order for a Black man to be vulnerable like that, they have to trust their provider. They have to have that kind of relationship. And so you have to build that trust. And even sometimes, just being Black isn't enough to build that trust sometimes. I had a lady, I do geriatric medicine, and I had a 70-some-odd-year-old lady who saw me today, whose blood pressure was 200 over 100. And she started out by her visit by saying that she doesn't do pharmaceuticals, that she does herbs. But I didn't, blast her for it. I wanted to understand, well, why don't you do pharmaceuticals? And she says, well, first it was religious. Her religious leader told her that you shouldn't take prescription medications, right? And so we had to deal with that. But then when it came down to it, I said, look, I understand that I'm going to have to earn your trust. And you got to know I got your best interest at heart. Okay. So I'm going to bring you back more frequently than I would the average person, because your blood pressure is so high. I'm going to get this lab work. I'm going to walk you through what's going on in your body. These are the implications of what that blood pressure is doing to you. And then let's talk about it. I'll give you a list of medications that I usually use. You go research them, look them up, and you ask me about every side effect, and I'll tell you what I think about that. And we'll just walk through this process together, because I want what's best for you. And in order for that to happen, I have to earn your trust. I literally had that conversation today with one of my patients. So, we have to have providers who care enough to be patient, to be understanding, and to go that extra step to want to earn and win that trust of their patient, and not have this kind of paternalistic, I'm the doctor, I lord over you, so you do what I say. That's not even the standard of medical training now. Medical training teaches what's called shared medical decision making, so that you don't walk into the room and just start launching out at the patient about, you need to do X, Y, Z. You open up with letting the patient set the agenda with an open-ended question. What would you like to discuss today with me? Or what questions do you have? What are you worried about? What are your health goals? And opening up that way, it opens the lines of communication such that in no more time, in the same amount of time, it's a mutual kind of interaction between the provider and the patient. So that's kind of what I think about how to approach those specific things with Black men, having over 15 years of having to have that conversation with Black men. They got to trust you, and you got to be vulnerable too. So, hey, I had my colonoscopy and this is what I went through. Let me walk you through it. As a matter of fact, I did an Instagram reel about my colonoscopy. Well, not the actual, in the colonoscopy, but, leading up to it, and me drinking my prep. And then after the colonoscopy, doing hey, this is what happened. Everything went well. And I'm okay on the other end of it. So I think that's what we have to do.
Thank you so much, Dr. Carter. There's so many layers to this thing. There's another question that's come in. This might be our last question before we switch to give resources to those watching that you can use, but this is an important one. The question is, how do you help those struggling with mental health issues when HIPAA laws make it difficult to get the right treatment and information to the doctors that the doctors need that would actually help the person? I might pass this to Ken to start and then to open this one up, because this is a real issue here.
Isha, can you repeat the last part of the question, please?
Absolutely. So how do you help those struggling with mental health issues when HIPAA laws make it difficult to get the right treatment and information to the doctors on that person's behalf?
Yeah, thanks for that question. Sometimes it is difficult at times to either get the proper consent, but sometimes we oftentimes have to encourage either the client or the patient that to release that information so we can get the either the appropriate medical notes, right? So we can make sure that they are getting the treatment and the care that they need. And so sometimes HIPAA is like a barrier. Is not it's a barrier, but it's not the barrier, if that makes a little bit of sense, meaning that we want to be able to encourage people to get the mental health services that they need. And as Dr. Carter was explaining, sometimes it just requires us to walk them through the process, to let them know that they're certainly the expert on their experience, but there are some things that we may know that could help them along in the process. So sometimes it is like coaching our clients to let them know what their options are, and also what their capacity to make decisions are. And so sometimes there can be some either logistical or administrative barriers at times, but we want to ensure that at all times clients are able to make healthy decisions for themselves, that we're able to explain all of their options so they can get the treatment that could be best for them. So it's not always easy, but we want to be able to ensure that if a person has anxiety or depression, or they're coping with PTSD, and we need to consult with their primary care doctor, we do as much psychoeducation as possible, providing them with the resources to make healthy decisions for themselves. So oftentimes we can get that release of information. So there can be a partnership with the either primary care doctor in concert with the psychiatrist, in concert with the mental health therapist as well. So, we're talking about a collaborative effort. And sometimes we do have to coach our clients just to let them know what treatment options are available to them.
Thank you. Any other builds on that piece?
Yeah, I'll say that, and specifically with this question, you can call me and talk to me or talk to the provider about a concern that you have about that loved one's care, and that's not a violation of HIPAA. So, like, if you're worried about your husband having some sort of depression or issue, whatever that is, you can call me. Now, depending on what kind of permissions or paperwork your husband signed, I may or may not be able to talk to you about it, but I can listen. I may not be able to confirm or give you any information about the patient, but if you want to call and say, hey, doc, I'm really worried about this, I want to know that, I may just say, okay, thank you. And that'll be it, because I can't, if I don't have a release or permission to, I can't divulge any information to you. But if you, call me and say, hey, I'm worried about this, HIPAA doesn't get in the way of that, but it does stop me from, giving you any of that person's, privileged health information. So I don't think that should necessarily be a barrier per se. Also, just as an aside, if sometimes people may have a loved one that may be having some mental health challenges or having mental health crisis, and they don't know what to do, there's a number 988 that people can call. And you can call 988 if you are having a personal kind of mental health challenge or crisis. But you can also call that number if a friend or a loved one is having that issue and you need guidance on how to help them. They will give you information and walk you through how to help that person as well. So those are, I think, just a couple of little bit more tidbits with that question.
Thank you for that, Dr. Carter. 988, instead of calling the police, to call 988 to actually get help for mental health care. Thank you for that. I know that we've discussed a lot today, but that today's discussion is just a taste of the type of health and wellness programming of both Delta and Kappa. So I'd like to ask Dr. Scales and then followed by Dr. Carter, if you could just leave us with one or two upcoming programs from your organizations that the people watching can tap into to continue this conversation and to continue on their journey to health. Dr. Scales.
Yes, thank you. So Delta Sigma Theta, we have our Live Well initiative, which is a part of our physical and mental health subcommittee. Every second Wednesday of every month, we have a topic of discussion related to physical and mental health. The upcoming one is going to be on May 8th, and it's going to be at 8 p.m. to 9:30 p.m. Eastern Standard Time. And the topic that we're going to be talking about is parenting special needs children. So you don't want to miss that. It's going to be May 8th on a Wednesday, 8 p.m. to 9:30 p.m. You can also check out deltasigmatheta.org, and you can see all of our past sessions as well, because they are located there and they're wonderful.
Thank you, Dr. Scales. Dr. Carter.
Yeah, so Kappa Alpha Psi also certainly has a physical health and mental wellness initiative. It's entitled Are You Okay? And the Are You Okay initiative is seeking to address the entire person, mind, body, spirit. And so please look at our social media pages, follow us on Facebook, on Instagram, because we as well will be having, various discussions such as this, but then also in all of our 12 provinces, which are regions around the country, we will be having, walks, we will be having panel discussions, we'll be having screenings, to really help improve the health of our community. Of course, through partnerships like this with Delta Sigma Theta and Johnson & Johnson, who they also have some wonderful initiatives that I think will be discussed. We certainly will be pushing forward with improving the health of our community.
Thank you, Dr. Carter. And I do want to share, in addition to those outstanding programs, a resource from J&J that's called My Health Can't Wait. And our website is myhealthcan'twait.com. This is a community wellness initiative of in-person events, online resources that addresses several medical conditions that disproportionately affect people of color. So it includes resources like one of the questions, Talk That Talk, a program with prostate cancer resources for Black men. That's My Word, with multiple myeloma cancer resources for Black men and women. Save Legs, Change Lives, a resource for peripheral arterial disease that affects the Black community at 4 times the rate of others and that can lead to lost limbs. Depression Looks Like Me for mental health. These are depression resources created for and by the LGBTQ+ community. And research includes me. It's a resource to increase Black and Brown participation in clinical trials. So if you go to myhealthcan'twait.com, you'll see information there for all of these different conditions, how to understand your risk factors, what and how to talk to your doctor, how to process these diagnoses emotionally, and resources that you can print out for your community. So I want to thank J&J. I want to thank Kappa Alpha Psi Fraternity Incorporated, my beloved Delta Sigma Theta Sorority Incorporated, for your commitment to health equity and mental and physical wellness. Stay tuned for the next episode in this partner series with our organizations, where we'll continue to dig deeper into issues at the forefront of patient care within the Black community. Thank you to everyone for tuning in, and have a great night. And thank you to our esteemed panel for all that you do to care for the community. Thanks to everyone.